Hello, everyone. Thank you for joining us today, spending a few minutes with us. Today, I would like to introduce Sonya Neumann from SCL Healthcare, which stands for Sisters of Charity Leavenworth, one of the Catholic programs that they've put up. Sonya is Senior Executive Director for Post-Acute Services and was instrumental in innovating and implementing their complex care at home model at SCL. Sonya?
Great. Thank you so much, Bill. Welcome, everyone. And I just want to give a little bit of background to why we went into this space and what it's all about. So complex care at home is a newer concept for home health and the healthcare at large. And just want to ground us a little bit in what that means. It really is bringing more complex healthcare services to the home environment in the community. And it is a very exciting and innovative approach to really a great intersection between the consumer-driven care that we're all seeing and experiencing in healthcare and care delivery at home. While some people may think that delivery of care in the home setting is a very low acuity type of work, it really has evolved over the years. And I've been in the business for about 26 years plus, and have seen it really improve and enhance the variety of things that we can do in the home with more innovation and technology, as well as more acuity. So complex care at home really is somewhat of a hospital admission diversion, as well as providing a different avenue for patients to be seen in the home to address their needs versus in an ED or hospital setting. So first and foremost, you have to have courage. It's not about the absence of fear, but rather the judgment that something else is more important than fear. Just because we've done it that way in the past doesn't mean that's the only way to do things in the future. And that's kind of a mantra that we have to make sure that we can do lots of a variety of things in the home care setting. Probably don't need to tell any of you things about the fact that, you know, we're certainly seeing a lot more elderly geriatric patient populations in a variety of settings, and we need to figure out how are we going to care for those patients in those settings, and do we need to look at other practice settings? So why move to hospital at home models? Certainly COVID-19 definitely accelerated this opportunity and provided us a definite launch pad to be able to accelerate this. For those of you that aren't aware, hospital at home has been around for over 25 years, just hasn't had a reimbursement source for it. So it's been something that some people have dabbled at and started programs and maybe written grants and that sort of thing. But the traditional payer sources have not been in alignment for that work over the last several years. Now we're starting to see some things move in that direction. Many of you are aware that CMS issued a waiver during the pandemic that still exists today. That was established in November of 2020, and over 100 and I believe about 150 healthcare systems have been approved for that waiver and have initiated the acute hospital at home. So I talked about a little bit that we wanted to ground ourselves in what hospital at home is. There are a couple of ways that you can get to hospital at home. Our product, or our pilot that we did at SCL Home Health, was based on a home health platform. And so, as I said, alignment with reimbursement is a challenge in this space. So traditional home health reimbursement can be somewhat difficult to manage your expenses and your revenue to be able to make the program work. So you have to be really cognizant of that. The other side of hospital at home type models is the acute hospital at home. And that's the waiver system that CMS issued in November of 2020. And that comes from a hospital healthcare system side of work. So that particular model is based on the acute care setting, allowing you to get reimbursed at DRG parity. And there are specific guidelines and regulations required around that. Today, what we're going to talk about is more the complex care at home model that I was privileged enough to partner with Kaiser Permanente and establish in the Denver metropolitan area as a pilot to really look at how we could do this model from a home health perspective. And so when you do this complex care at home, hospital at home model for the home-based patient from a home health traditional reimbursement model, it is challenging. You have to meet all of the regulatory guidelines for home health. And then we were fortunate, like I said, to partner with Kaiser Permanente. So we were able to negotiate a reimbursement day rate that was more effective for the services that you provide in a more acute setting. And that acute setting is in the home, but you have more resources required for that. So, COVID accelerated interest in this area, and I think really has had a profound difference in how we do this type of work. There's been 25 years worth of work around the hospital at home work internationally, and so we've just been waiting for that catch up for the reimbursement and the actual development of the program. So this kind of lines out what I spoke about as far as the home health-based care model that functions in the home health reimbursement resource model, and you have to meet the specific home health criteria. So when you have a patient that has more complex needs and you have an increase in frequency of visits from your nursing staff and that sort of thing, it can be a challenge from the reimbursement side. Acute hospital care at home is hospital focused, allows the parity of the hospital DRG system. And as of May 7th, there were 56, I believe there's up to over 130 or 150 hospital systems now. So this kind of just gives you a visual representation of how high tech meets high touch in the home setting. We used a lot of technology and partnered with our remote monitoring vendor, Vivify Health, to be able to bring the technology to the patients in a very prompt way and be able to be connected with them. One of the inclusion criteria for our program was that they had to be receptive to the technology and had to have the means in which to operate the technology, because key to our clinical outcomes would be to make sure that we could monitor them. We set up a monitoring system 3 times a day to be able to monitor their biometric opportunities to look at all of their biometric information at 8, noon, and 6 p.m. And then we also had the availability then to do video visits. So virtual care was important as well. So really what our program development consisted of was really setting the stage and working very closely with our partner in the system. And so what SCL Home Health did was we brought the nursing services and the technology side of the equation. And then in working with Kaiser Permanente, they were actually the payer as well as the provider and logistics side of the equation. So when you're looking at all of the development for a complex care at home program, you have to look at all of those specific areas. So we were able to blend that technology with the in-person care needs. They were able to bring a provider to the home setting to be able to do an in-person visit jointly with our home health nurse, which was fabulous. And if any of you have experience in home health, it's like a dream to be able to have your provider there to reconcile medications and be able to get orders and establish your plan of care immediately. So that was really a wonderful portion of the program. We were able to do assessment and education of the provider community to achieve adoption of the new concept, overcoming provider fear in the home capabilities area is really important. There are several physicians that we ran across that were hesitant to accept we could do this in the home setting instead of an ED or an observation stay. So that is a really key point in developing your program is your communication plan and really being able to identify what is going to be required for acceptance. Finding the right partners for technology, network of services, and that is inclusive of pharmaceuticals, DME, oxygen, all of those types of labs, all of those types of services so that you have that all ironed out and make sure that you have that very efficient so that it is very timely. That tends to be the biggest concern from a logistics standpoint is making sure that you can get all of those things timely. Remember, most of these patients, typically, if you're doing an acute hospital at home program, they're being evaluated and diagnosed and a lot of diagnostic pieces done in the emergency department before they would be coming to your home program. In the complex care at home, have a little bit more flexibility because the patient could come from a clinic, could come from urgent care, emergency department, or shortening an observation stay at an acute care hospital. All those avenues we saw in our pilot to be able to have patients come to our services at complex care at home. So there's different types of things that can be done in that specific diagnostic arena. So development of case management throughout the program, length of stay, really providing oversight. And I'll talk to you a little bit about some of those specifics as we go through the development of the program. Making sure that you have good clinical and operational competencies to ensure success. Again, communication plans internally and externally to your healthcare system is important. Collaborative partnerships with stakeholders to achieve those streamlined workflow and working relationships, and then developing the appropriate reimbursement. So how complex care at home meets the advanced medical care at home, which is the acronym, or AMCA is the acronym that is utilized by Kaiser in that partnership. It was a strong blend of virtual care and in-person care. We spent several months developing the program, and we set it up to have 3 remote monitoring sessions per day, and then daily nursing care via in-person, which is mandatory on day 1 and 2 and the day of discharge. The other days, depending on what was going on with the patient, could be virtual visits if appropriate for their care. And then the provider would like I said, start the services. Usually whenever we would get a referral for complex care at home, we would initiate that referral within 4 hours on the home health side of things. So if we received the referral before 5 p.m., then we would have a nurse that would initiate the technology. So we would get the remote monitoring kit in the home and do the initial assessment. Then the next morning, that nurse or another assigned nurse would meet the provider in the home to establish the full plan of care and move forward with all of those pieces. So it really worked well from that perspective. We would also, for that working relationship and collaboration, we would have daily collaboration huddles. So at 9:30 every morning, the providers and our coordinators from the home health side would huddle via phone conference, and that worked really well to provide that extra layer of case management. We could determine if there were other needs that the patient had, and also to identify whether or not they would be transitioning to traditional home health needs, or if they were able to be discharged completely at the end of the length of stay. So really good, clear communications is important. I apologize, this slide might be a little bit small and difficult to read, but you can see very clear inclusion and exclusion criteria was established. The means of establishing this was really based on good clinical judgment of medium acuity type of patients that could benefit from the complex care at home. So we also looked at being able to screen them. We did a BIMS screen on that first visit when we visited the home to make sure that cognitively they were able to manage the technology, or they had a caregiver that could assist them, so that we didn't get into any issues. You know, sometimes patients can say, yes, we want to participate and do the work of participating in that plan of technology, but sometimes they're not able to. So we really worked hard to try to identify that right up front. So day one, we would do what we call our mini open. We'd set up the remote monitoring, deliver the kit from the office, and install all of those items, and do a head-to-toe assessment and initiate the basic plan that very first day, and then meet the provider in the home the next day. So you can see usually on day one, depending on what time we got the referral, most of them were late afternoon. So depending on what time we got the referral, we would either have 1 or 2 transmissions of the remote monitoring. And I can't tell you how important really connecting that technology is in a program like this, because we were able to really utilize the uniqueness of Vivify Health is really about biometric measurements as well as the individualized care plan. And so when it pushes out, the system allows you to push out the individualized care plan. We actually designed a complex care at home care plan or care path for these patients, so that we could request the appropriate biometrics, as well as provide very focused and targeted education and symptom questions, so that after that first couple of transmissions, remember we're doing it multiple times a day. A lot of remote monitoring in our traditional home health remote monitoring program only calls for 1 time a day physiological monitoring to be transmitted. And so with this, you're doing it 3 times a day. You want to make sure that the questions are seeking the right information and drilling down on the care plan. So that was really imperative, that our central monitoring nurse function really becomes a little bit more of a case management type of function to make sure what's going on. For example, there was a patient early in our cases that allowed us to see that they were having some additional respiratory issues, and we had planned to do on day 3, we had planned to do a virtual visit, but when we did our huddle that morning, identifying the answers to the care path questions and the biometrics that came over, we changed that to an in-person, because we wanted to get a stethoscope on the patient to assess their respiratory status more. So things like that really allowed us to be very flexible and very nimble in meeting the patient's need, to be able to make sure that that was appropriate for the patient. So you can see after we did the initial setup with the remote monitoring, then we would communicate with the logistics hub with Kaiser and make sure that if there were any other needs for the patient, as well as when the provider would be scheduled to meet the nurse the next day. So you can see basically that same information. If we needed to do a second virtual visit by the nurse, we could. Most of our cases, that was not required, and the providers also could be able to do additional virtual visits. And with Vivify Health, it allows you to add in additional care team members. So we didn't have the need during our pilot, but if we had the need, we could have had the physician, the nurse, and the patient all video conference together. So that's helpful. Then as you go through the process with complex care at home, the typical length of stay for our complex care at home patients was no more than 5 days. And so we really look at what do we need to do in order to be able to either transition them to traditional home health or be able to be ready for discharge at the end of that 5-day stay. So we had a very defined best practice care path that we followed. And you can see that 8, 12, and 6 was the monitoring times, and then really customizing their care plans as we've discussed. So then on the last day of service under the Complex Care at Home program, or day 5, we would do an in-home nursing visit to collect the discharge assessment data that's required via home health regulations. And we would notify our central monitoring station team that they were being discharged or transitioned to traditional home health. We saw a lot of heart failure type patients, and so many of them needed traditional home health services. So if that was required by the patient, then we could certainly do that. So that's what this addresses here, is that if we had need for continuing to monitor their biometrics, do additional teaching, additional assessment, but they were not as acute as required for the Complex Care at Home program, then we would roll them over into traditional home health and finish their care path that way. So some clinical considerations and symptom assessment that we found in our program is that the Vivify Health platform of patient remote monitoring really informed the clinical team of the patient's status through the biometrics and those symptoms questions. And this population required more frequent monitoring and communication of transmissions to the care team with escalation to the provider as required. It was great. We had a very open communication. We could text directly or call directly to the providers, which is really key in this type of acute programming. So as you're thinking about developing a complex care at home off of the home health model or off of the acute hospital at home model, you really need to think about your modes of communication and availability, because I really truly believe one of the linchpins of the program is that open collaboration and really key availability right away to the providers. And you know, the home health nurses are used to doing a lot of things autonomously, but we can't function without orders. And so you would either need to develop more standing orders types things, which you have more latitude to do that from the hospital setting than we do in the home health setting. So there's some nuances that you could flesh out as you review the regulations and the program requirements from the acute care side. So the goal is to provide safe and effective care in the home. the patient's condition requires a higher level of care, you coordinate that activity with the provider for the appropriate path. They may be eligible for a direct admission to a SNF or an ED admission to observation and that sort of thing. So really working together as a collaborative clinical unit, if you will, and utilization of your technology is key. So virtual visits for support, your patient remote monitoring, physiological monitoring, those sorts of things. So all interventions and care coordination are documented or were documented in our EMR and visible along our continuum of care. So general AMCA care path was initiated for day one of employment or deployment. And by day two, we really did look at fine tuning that because they were very general. And that's key to really identify what symptoms are you needing to drill down on and how you can identify how to customize that for the patient's needs. That really helped with moving the patient along effectively. And after hours patient calls, we had go through our standard traditional home health on-call system and triage per our protocols. So here's kind of our pilot results of our 8 patients. We had 100% positive satisfaction ratings. And one of the real key things for a hospital at home program is that you want to deliver good quality, you want to have good clinical outcomes, and you want to have good satisfaction and experience scores. And so we feel really good about the work that we did. We had 100% visit utilization target length. So we had our patients were 2 to 5 days in length of stay. We didn't have to escalate any patients to a higher level of care. We did have a 25% acute care rehospitalization rate. Number of the participants requiring hospital emergency care in the 30 days after the program. So it wasn't immediate in that regard. And we didn't have any unintended mortality rate. We did have one patient expire while on the program, or right after she was admitted back to the hospital for a respiratory issue, and did expire in the ICU at that point. We had 62.5% of the complex care at home participants converted to traditional home health care after their 2 to 5 days worth of complex care at home. So that was beneficial for the patients, and I think certainly leads to providing more information and education on what traditional home health can do as well. So that really is a quick overview of our complex care at home program. I just can't say enough about how important it is for collaboration with any more acute type of work that you do. It's really important to have that case management oversight and moving the patients along so that you have optimal outcomes. And I think that was really key to our success. And I believe now we are going to open it up for questions and answers. So I will turf it back to you, Bill. I'm not hearing you. I think if you hover at the bottom of your video, you'll see to take off your mute.
Can you hear me now?
Yes. Feel like you're on a commercial.
No, I can't. So question 1 that we've got from the audience: once a complex care at home program is up and running and operational, what, if anything, would preclude patients being admitted to it directly from urgent care centers and doctors' offices rather than a hospital?
So depending on the type of program that you have established, so if it is a hospital acute based hospital at home program, there are specific regulatory requirements that you have to satisfy, and that patient has to be evaluated in an emergency department or an admission to a hospital before they can then be transferred to the home setting. If your program is a complex care at home program like what we did, and it's based on a home health model, you could absolutely see patients directly from any of those settings, as long as they qualified for the home health criteria. So they're under the supervision of a provider that's qualified to order and certify for home health, that they have skilled need, and that they're homebound. And so it's pretty easy to meet those criteria for this population. So if you're on a home health platform, you can do that. Acute care, like I said, there are specific regulatory requirements that you have to do, and that is, they have to be evaluated in an inpatient setting and then transferred home. And they have specific disciplines of clinicians that need to see them on a daily basis. Nursing and I believe paramedics are also approved in that regulation. So you'd have to consult those regulations specifically.
Thank you. Question number 2. What are the primary differences between the inclusion care criteria for this model versus traditional home health model?
For a traditional home health model, you certainly wouldn't require that they have to be able to do technology. You want them to be able to if you have that capability in your program, but you wouldn't require that as an exclusion criteria. In the acute setting, you would have that as an exclusion. There are also things that require extensive diagnostics through their course of stay that might not be appropriate. So there's more specific, like medium acute type of care that would be appropriate for the traditional home health as well as the acute care home health. But the acute complex care at home type of population usually requires much more intensive services. So that's where you would want to have a different reimbursement system, because the traditional, if it's a commercial insurance payer or if it is a traditional Medicare payer, may not cover the extensive amount of needs that you might have. So typically we don't do a lot of daily nursing or PID nursing, those sorts of things under traditional home health. You can, and you will if it's required, but usually there's some nuances there that would require you to look differently at that patient population.
All right, thank you. The third question is, what is the cost of this service?
The cost as far as the expense or the reimbursement? I guess I could address both sides of that. The reimbursement for the service would be parity for DRGs from the hospital side if you had a hospital program. So the acute hospital at home program would be paid the same as if the patient was in the hospital for their disease processes through the DRG system. So that's how that works for the acute care hospital side. As far as for the home health side, you're paid the same as you would be in any traditional home health model. So if you have commercial insurance payers that pay you fee for service, that's how they would pay you unless you negotiated something different. In our program, we negotiated a day rate. So I calculated what I felt would be the average cost that it would take to do the technology, right? Virtual visits, remote monitoring, daily nursing visits, we calculated a very small percentage of the patients would require therapy evaluations during that first 5 days, maybe a social work evaluation, those sorts of things. So we wrap that into our daily rate reimbursement. So it would depend on your cost of care and what you needed to cover your costs, if that's the cost question.
Yes, so I would just like to add a little bit to that, I guess. Vivify Health, as the technology that SCL is using to provide this care at home for the patients, as Sonya said, for the remote patient monitoring, so for the virtual visit consults, as well as for the daily pathways or care plan, the questions and the assessments and surveys that the patient is asked. I would just say it can be, from the technology cost, it depends on the complexity of the program, the number of devices, the tablets that are utilized as that interface for the patient, all of those things, some of the additional features and functionality. It could be as low as $25 per patient per month, up to $100 or more per patient per month, depending on what the technology solution was that was provided for that program. So question number 4, what type of physicians are best for this complex care at home assessment?
Well, very good question. Our partner in our pilot project with Kaiser Permanente, they used their SNFs. So that was the population of physicians that they felt could be pulled in and out to do home visits. And so they did a rotation with their SNFs, and that's who supported us. And they did a great job. We also have a program that we work with Kaiser on, which is in-home palliative care supportive services. And so they have palliative care physicians that visit in the home and meet the home health nurses as well. So they also are very qualified. It really just depends on what you select as your patient population and, what you're comfortable with. A lot of programs, I believe, across the nation that I've read about also, obviously utilize emergency department providers as well. I think any provider that has the competencies required to do those types of assessments are appropriate. It doesn't have to be just emergency department physicians, but it does need to be somebody that has the competencies to be able to do those assessments. And there's not as many diagnostic things that are going to go on in the home setting, which is actually one of the cost-saving measures for the program. So you have to really be keyed into symptom management and understanding what's going on with the patient, and which is a little different than, the best practices that we see in our acute care hospitals, because they can order lots of different tests and those sorts of things. That's really not this population.
Thank you. Mm-hmm. And Sonya, for this program with SCL, you talked about inclusion and exclusion criteria. Is there one or two criteria that come up the most often?
Not really. Like I said, because our patients were in a complex care at home on the home health platform, we have to meet the qualifications for home health. So that's definite. They have to be homebound. They have to be under the supervision of a provider that's qualified to certify and supervise home health patients, and they have to have a skilled need. So that's the basic pieces. But as far as the inclusion, if you look at the data that was shared on that slide, you can see the basic diagnosis, if you will, or disease processes that most of the patients fell under. We saw most of our patients were congestive heart failure patients. So cellulitis patients, congestive heart failure patients, COPD patients, those types of patients are really good for this program because they need close observation. They need to get evaluated as to whether or not they have more needs for education, that sort of thing. So maybe they're appropriate for traditional home health after they get through their acute phase. Those are really the things that you need to be watching for, is those patients that really need assessment and observation a little bit closer. One of the things that we did see in our program that I thought was interesting and didn't expect initially, but it makes sense when you look retrospectively at that. But we saw a lot of the patients coming from observation stays. So instead of staying in an observation stay for 5 or 6 days, which some of them do, they were discharged to home after 2 or 3 days, which, you know, improved the length of stay for the hospital, but also then got them to their home setting and were very effectively treated in that setting. So it was kind of a shorten the length of stay, not necessarily completely diverse completely from being admitted into observation.
Okay, thank you. The slides from Sonia's presentation will be made available after the webinar, so you can scroll back through and look at those exclusion and inclusion criteria if you'd like. So I've got another one. For this complex care at home program, is it designed only for complex patients discharged from a hospital or SNF, or could it include one of my patients, this question is from a provider, that I presently manage in the home whom I would consider complex?
You could, yeah. I mean, we would need to evaluate whether or not the patient met traditional home health criteria and can just be admitted through traditional home health. But certainly a complex care at home patient can be admitted directly from a physician's practice or urgent care or the ED, as long as the program that you're seeking is on a home health platform. If it is on a acute hospital at home program and that is what you're looking for, then there's regulatory requirements that have to be met. So they have to be evaluated in an inpatient setting through the ED or an actual admission before they get discharged to home. So if you have a complex patient that has needs, I would encourage you to evaluate whether or not traditional home health is appropriate, because it likely is. We can do a lot of things in traditional home health. So just because the patient's complex doesn't mean it needs a complex care at home admission. It could be just a traditional home health admission.
Right. So in setting up this model and implementing the complex care at home program with your partners, what would you say was the biggest barrier to rolling it out, and how did you overcome that?
I think the biggest barrier to this situation was the communication plan to providers for acceptance, because again, the hesitancy of, can you really do that in the home safely, was a big issue. And while Kaiser really did go back and try to promote that more with their providers, I wouldn't say that we overcame it. That was a difficulty. So it's really about the culture of acceptance. So that would be something that if you're looking at developing this program, that would be the first thing that you need to be evaluating is how are you going to communicate and gain acceptance of your providers, because they don't refer to the program, you don't get any patients on the program. So that's really the key, I think, stumbling block. I would say the second piece of it that took probably the longest was really developing the logistics plan to be able to bring in all the different providers that were necessary and make sure that you could get a good turnaround time in the community. You know, if you have somebody that's on oxygen or needs to be on oxygen because they have respiratory compromise and your vendor can't get it there on time, that's not going to work. So you have to, infusion and oxygen probably are your two largest partnerships that you need to make sure you have well ironed out the logistics of how that's going to work.
Okay, great. Next one. When using Vivify Health, did you use a number of pathways related to the disease of the patient that was admitted? Or did you have an additional complex care kind of customized pathway for their specific diagnosis or for the program?
Yeah, so remember the sweet spot for the number of patient questions and education items and all that is about five items. Okay, so we're asking patients who don't feel good already to do this 3 times a day. So it can't be repetitive. It needs to be something that's going to engage them. You also need to make sure that it's individualized enough to be able to capture the data that you're looking for to say, do I need to make a virtual visit this evening? Or do I need to make a home visit the next day versus a virtual visit, those sorts of things. So we did not use the standard care paths that are available in Vivify because those are 45-day plans. So you may not get the right symptoms addressed in a 5-day window 3 times a day that you need. So I wrote our own care paths, and I used very general. I used the Vivify questions. I pulled out questions out of some of their care paths that were generalized symptom questions. So are you nauseated? Do you have pain? Do you know, those sorts of things. And then after the first transmission, and we had a little bit more knowledge about what was going on with the patient, reviewed the clinical record, reviewed the first transmission. We had data from the in-person visit that first day. So then we could go in and we could massage those questions and get more specific. And so it was really a very manual, individualizing system, which is great that Vivify allows you that flexibility to do that. So we had the basics planned so that you could get the first transmissions going, but then we did get informed by their responses and their disease process where we needed to go from there, and then customized it from there. It worked really well.
Yeah, so Vivify allowed you to customize the program to your specific needs and specific patients even.
Yes, yes.
All right. What is the minimum length of stay required for complex care at home patients? Is it 2 midnights?
There is no requirement. Again, well, I'm going to answer that based on the complex care at home. I would refer you to the regulatory requirements for the acute hospital at home, because I don't know that information off the top of my head. That wasn't our program. So I would refer you to the regulatory guidance on the waiver to know specifically on that side. But on my side for complex care at home on the home health platform, there is no requirement for a set number of days. I had a requirement from a reimbursement standpoint and a commitment from my payer that they would pay me 2 days, no matter if we did 1 day or not. I required 2 days because that would cover my initial costs of getting things set up, even if the patient ended up going back to the hospital or whatever the situation was. So that's a negotiation that you would need to do with your payer.
All right, thank you. And then on average, how many days did patients need complex home care for?
We only had one patient that was 2 days, and that was because she was no longer homebound and wanted to get back to her other activities. She still needed some care, but she sought that through her physician's office. Everybody else was right at the 5-day. And like I said, I believe 62.5% then transitioned to traditional home health. So we discharged them from complex care at home and readmitted them to traditional home health within 24 hours of completion of the program.
And then the rest of the patients just continue to recuperate at home outside of a home health program?
Correct.
All right. Excellent. I think that's, let's see, we've got one more that came in here. On the alignment of patients' and providers' interest, are hospitals concerned about being over capacity as more and more patients are treated at home?
Okay, so yes, that's always the million-dollar question, right? So if you're doing a program that is diverting patients from being inpatient, is that a problem? Or do you have hospital systems that are at capacity or over capacity and need offloading? Is that possible? That's really the questions that have to be answered. And I would say, and I'll speak just for my own philosophy on care at home, that's the wave of the future. That's where we're going. Consumers want to get as much care conveniently and individualized as possible. And if they can do it in their own home, you know, they're less likely to get delirium. They're less likely to get hospital-acquired infections. They're more likely to engage in virtual care as well as in-person care. That's the wave of the future. I think that's where we're going. And I think we'll see that develop more and more. And the diversity of what you can accomplish in the home setting is so much better than what you could years ago. So I think we'll continue to move in that realm. As far as the, I'll use this term loosely, but the fear factor of, oh, patients are only going to be seen in the community and not in the hospital. I think hospitals will continue to have extreme need because there are patients that are in the exclusion criteria, right? For our programs and for other programs, they need to be inpatient with 24/7 care. And so there is the right level of care for every patient. So I think we'll see just things change. Hospitals are going to become even more acute than they are today. And those patients that can be seen in the community will be seen in the community.
Well, thank you so much, Sonya. We're going to wrap that up for today. Again, I want to thank everyone for attending and sharing some time with us and learning a tremendous amount about the complex care at home program that SCL does and hospital at home in general. Again, Vivify Health has been very happy to sponsor this webinar, and the recording and the slides will be available to all attendees post-webinar. Thank you so much for attending.
Thank you.